Hello and welcome to another edition of Facebook Live with Advanced Pain Care. Well, we take a couple minutes to allow everyone to jump on. We're going to start with some introductions. First and foremost, Dr. Malone, you're our founder, our president. Could you tell a little bit about yourself for anyone that's new to joining us today?
Hi, Sam. Thank you for the introduction. I'm Dr. Mark Malone, the founder and president of Advanced Pain Care and now Advanced Neurosurgery. I'm here with Dr. Shawn Moore. We're going to talk about minimally invasive surgery and other aspects of outpatient neurosurgery, which I think is a very important topic today, especially post-COVID, because no one wants to have surgery in hospitals anymore. We can do it much more efficiently and with less expense and less risk as an outpatient surgery. So I'm very glad to be here with Dr. Moore. Thanks, Sam.
So, Dr. Moore, you're such a wonderful addition to Advanced Neurosurgery. We're thrilled to have you. Could you tell us a little bit about yourself and your specialty?
Yeah, my name's Shawn Moore. I'm a neurological surgeon. I trained at the University of Texas Southwestern Medical Center at Dallas. I was very fortunate to train at such a large and quality institution here in Texas. My background is neurological surgery, so we basically treat surgical problems of the nervous system. So that includes the brain and spinal cord. As you're well aware, lots of problems in the spine cause chronic pain. So we treat lots of disc herniations, we treat fractures, we treat dislocations and trauma of the spinal column, spinal cord tumors, basically anything that affects the nervous system we try to address surgically in patients that are beneficial from these techniques.
Well, wonderful. So normally we let the Facebook audience submit their questions, which we still want y'all to do. But today we're going to have a little bit different style. We really want to hear from both of you guys on how pain management, neurosurgery works together, along with details about our surgical center. So Dr. Malone, could you just start the conversation?
Absolutely, Sam. Thank you. Chronic pain is a multifaceted disease state, and it requires multiple specialties to fully address it. That's why we're so glad to have our colleagues in neurosurgery, as well as our colleagues in interventional pain management, orthopedic surgery, and rheumatology. We all work together to crack this nut that is, a big cause of pain and suffering worldwide, but especially it seems in the United States. There's a lot that each of the specialties contributes to this, to the management of chronic pain. And with that said, I'd like to ask Dr. Moore. Dr. Moore, what do you think, what is the connection between neurosurgery and chronic pain?
That's a great question, Dr. Malone. I think chronic pain can come from many sources. Chronic pain can come from patients that have prior injuries like trauma to the nervous system, trauma to the spinal column, scar tissue, previous peripheral nerve injuries can cause complex regional pain syndrome. And also patients get depressed, when they have chronic pain. It affects your entire quality of life. I mean, it basically affects every facet of your system complex, and that's why you need something like advanced pain care that's going to take a holistic, comprehensive approach to you. If you see an orthopedic surgeon, you're going to get an orthopedic procedure traditionally.
Yeah.
Same thing if you see a neurosurgeon, you get a neurosurgical procedure. The nice thing about advanced pain is we offer all of that, under one shelf. So you get evaluated by the interventional pain specialist, the medical pain specialist, the rheumatologist, the orthopedic surgeon, and we all confer on these patients and figure out the best treatment algorithm for you on an individual case basis.
So a patient's more likely to get exactly the specialist that he needs.
Absolutely.
Yeah. Because if I see a patient with a neurological or a neurosurgical condition, it's easy for me to walk across the hall and say, hey, can you see this guy?
Absolutely.
Yeah.
We're under the same shelf, same roof.
That's awesome. So you're an expert, you're known to be an expert in minimally invasive surgery.
Yes, sir.
Minimally invasive neurosurgery. How do you address some of the issues that come up that cause chronic pain as a minimally invasive surgeon?
That's a great question. Well, the first thing is we traditionally try non-surgical treatments in all of these patients. So in the patient that presents to us with either acute or chronic pain, we'll make sure they've been evaluated by an interventional pain specialist. We make sure they've had maximal medical management, physical therapy, injections, all those types of things. And if those things all fail, then we'll often look at surgical options.
Yeah.
You know, in the past, all these surgeries were traditionally performed open on an inpatient basis.
Yeah.
And in selected cases, they were very successful. You know, in other cases, they could cause failed back syndrome or chronic pain syndromes themselves. Nowadays, I was fortunate enough to train in Dallas at a real big institution when these techniques were coming out. So I hate to age myself here, but in the early 2000s, and these techniques have really grown in popularity since that time. So we now perform these surgeries through smaller incisions. So that's basically what minimally invasive spine surgery is. So in the past, if you had a laminectomy, you know, you might have a 5 or 6 inch incision. They split the paraspinous musculature. They take out the interspinous ligament, the spinous process, the lamina, the facet joints, all those things open. And in selected patients, they did well. But nowadays, we can do that through a small 1/2 inch incision. So we basically put a port in the back. We approach it with a microscope or an endoscope. We do the same basic techniques. We still decompress the nerves, because that's the goal of the surgery, is to alleviate, you know, nerve compression that's contributing to the patient's pain syndrome. But then at the end, you know, we close through that small incision so they have less scarring. It's a shorter operation.
Yeah.
We've moved that into the outpatient sector, so you can actually go home the same day, and you're typically recovered or back to work shorter than with the traditional open procedures.
Describe, you know, you were describing the larger open procedure for back surgery. How does that cause chronic pain?
That's a great question. I mean, there's many pain generators in the back. You know, neurosurgeons often focus on the disc because that is a common source of pain that we see, but you can also get pain from the facet joints. You can get pain from the muscles. You can get myofascial pain syndrome. You can get pain from nerve injuries or cut nerves or things like that. So basically, anytime you have surgery, unfortunately, you can have pain from the surgical procedure itself, although the goal of the surgery in many cases is to alleviate the pain by treating the actual nerve root compression or disc herniation or stenosis that's present in the back.
So sometimes a big surgery can make it even worse.
That's true.
That's awful, because you're trying to treat, you're trying to get better, but you have this big surgery, and the next thing you know, you've got more nerve damage, right?
Yes, sir.
So nerve damage is a big bugaboo. But with minimally invasive surgery, you're less likely to hit nerves or stretch nerves or damage nerves.
That's right. You have
Yeah.
smaller incisions, so it's smaller exposures, it's shorter operations, it's less blood loss, there's a low risk of complication. You tend to go home the same day, so you don't have a prolonged hospitalization. So you have lower risk of pneumonia and deep venous thrombosis and things of that nature.
So how does minimally invasive neurosurgery help, say, with a herniated disc?
So typically with a disc herniation, the patient would present with either, you know, leg or arm symptoms, depending if it's cervical, lumbar, or even, you know, rib cage if it's thoracic. So they have a disc herniation that's classically compressing a nerve. So we do a small paramedian approach. So instead of a large incision along the midline, we do a small, you know, typically 15 to 17 millimeter incision off to the side of the spine. And we put a port in there, which is just a hollow access tube. And then we use special instruments to go through that with a microscope or an endoscope. We basically trim the disc that's compressing the nerve, and that alleviates the nerve root compression.
So you're looking through a microscope.
Yes, sir.
It's like little tiny scope that spreads apart the skin so that you can get to the nerve root. So a herniated disc compresses a nerve root, and that causes chronic pain.
Yes.
So you have to go in there and decompress, or in other words, move a little piece of that disc. Right?
Correct.
Okay, and that helps.
Yes.
How often does that help?
I think probably 85 to 90% of the time.
That's darn good in the
Yeah.
world of chronic pain.
Yeah, it's high. It's not 100%, and you can get complications. I mean, you can get scarring afterwards, often called epidural fibrosis.
Yeah.
That can cause residual persistent symptoms. You can get recurrent disc herniation. You can also get progressive degenerative disc disease at that segment where the disc collapses. I think that risk is less with minimally invasive surgery as opposed to open surgery, because you're not devascularizing as much of the paraspinous musculature. You're not taking the interspinous ligament, which is kind of important for support and stability.
Yeah.
You're not taking the entire spinous process and lamina out. You're doing only smaller openings, but those things are still possible with minimally invasive approaches as well.
Yeah. So in the world of surgery, a lot of times less is more.
Yes,
right?
sir.
And your name is Dr. Moore, so
Right.
good connection.
It's perfect.
That's perfect. Easy to remember. Less is more.
Yes, sir.
Minimally invasive surgery is better, or more surgery in many cases. How many of your patients, Dr. Moore, have already had surgery and don't need a decompression?
That's a good question. A lot of the patients we see, particularly advanced pain care, are complicated. So they've had other surgeries out in the community. They've had other interventional pain procedures. They've had lots of different things done to them already.
Yeah.
So lots of times the most important question is, you know, is it better to avoid surgery? Is it better to hold off at this point, try to manage them with other modalities?
Yeah.
So I traditionally use either patients that have failed, all non-surgical treatments with progressive pain syndrome, or on the other wing, patients with progressive neurologic deficit. Those are the ones who are more aggressive with. So the patient that has progressive numbness and weakness in their leg, with residual stenosis, we might treat them more aggressively than we would someone that has isolated pain syndrome, where we're going to try to treat non-operatively as long as possible.
Right. Now I understand you're also an expert in spinal stimulation.
Yes, sir.
When do you need a spinal stimulator?
That's a great question, and fortunately the indications for spinal cord stimulators are expanding literally every day. In the past they were kind of limited to patients that had failed back surgery syndrome, and had prior surgeries, had persistent pain or nerve injuries or complex regional pain syndrome, previously called reflex sympathetic dystrophy. But now the indications are expanding, even peripheral arterial disease, patients with chronic angina that's not controlled, patients that have nerve injuries where they have residual pain from that, phantom limb syndrome. The indications for stimulation are expanding every day, so it's pretty exciting.
Many, or maybe even most of these conditions have a common denominator, which is nerve damage.
Yes, sir.
Right? So would you say that barring the need for decompression, nerve damage is the most common reason to get a stimulator?
Absolutely.
And how effective is a stimulator when you have nerve damage like this?
They're highly effective. I'd say 85 to 90% of the patients that we put through trial with positive results have improvement after stimulation. So the nice thing about a stimulator is that you can figure out if it's going to work before you even have the procedure.
Yeah.
So you go through a trial where the interventional specialist just puts a small needle in your back, passes some electrodes up along to the area of interest, and then you go about your daily business for a week with a stimulator in place. And if you have a positive outcome from that, then you have the definitive stimulator placed underneath the skin connected to a small battery. So the nice thing is the vast majority of these are done percutaneously on an outpatient basis, even without general anesthesia. So there's more complicated patients that have had prior surgeries. They have a lot of scarring in the epidural space. Maybe it's hard to pass these electrodes where the surgeon's going to place larger paddle electrodes, or if they need more diffuse stimulation. But in general, these are outpatient procedures even without general anesthesia, which is amazing.
So you can just put a tiny wire in a patient's back through the skin with just a needle, right?
Yes, sir.
So not an invasive procedure at all.
Right.
And they just go home and then they test it out for a few days. So this is really just a test.
Right.
It's like a test drive of the therapy that may really save your life.
Right. If you don't like the car, just return it.
Yeah. Right? Have you ever had a car that you returned?
No, I haven't.
I haven't either, actually. If they let you have it for a few days, you're probably going to end up
Right.
keeping it. Actually happened to me one time, but that's a different story.
So Dr. Malone, I'm going to go ahead and jump in here. You guys really make my job easy because you've answered almost all of the questions that have come in through Facebook Live. So I'm
That's
scratching
amazing.
those off as they come in. A couple things that haven't been covered just yet are, what is the process if somebody feels like maybe neurosurgeons tossed around another doctor's office? What does that referral look like? Do patients need a referral? What do they need to come with to when they present to see you, Dr. Moore?
All they need to do is bring their body. So no, that's a great question, and we treat all comers, and we pride ourselves here at APC at trying to get patients into the next available appointment, typically within even a couple of days. So we try to schedule you immediately. We'll evaluate you. Lots of times we will order imaging studies, so if a patient has chronic neck pain and it radiates down the arm, and say they have numbness or tingling in a certain distribution and we're worried about nerve compression or disc herniation, we'll typically get an MRI of the cervical spine. That kind of gives the best view of the spine. We can also do CT myelography to look if the patient can't have an MRI for other reasons, if they have a pacemaker in place or something of that nature. But the imaging is important, but the history and the physical is even more so. So it's really talking to the patient, figuring out when their symptoms started, if they're progressive or not, examining them, seeing if they have any evidence of nerve damage, and then correlating that with the imaging studies to see what the next best step is, whether that's physical therapy, interventional pain evaluation, spinal cord stimulation, or a surgical procedure.
So Dr. Malone, we've touched on how pain management and neurosurgery works together. If a patient's watching this right now and they're like, well, who do I see? Who do I see first? Could you tell us a little bit about that process?
Well, yes, absolutely. If pain is your predominant complaint and you don't have muscle weakness or prior spinal surgery, then your pain management doctor is the best person to see first. If he feels like you need neurosurgery, you can see the neurosurgeon the same day or maybe the next day. But we'll take care of your initial pain evaluation. Now, if you have muscle weakness, you definitely want to see a neurosurgeon, and I would say see him first. Although if it turns out to be more chronic pain issue, then again, we'll see you the same day you see your neurosurgeon. So that's what we pride ourselves on is cutting the red tape and seeing the patient same or next day that he calls us, and getting you to the right specialist early rather than late.
So we have a couple follow-up questions to the spinal cord stimulator that you guys have talked about. The first one is a stimulator permanent?
It is permanent as long as you need it. If it gets to the point where you don't need the stimulator anymore, it is removable. So it's a completely reversible procedure, which is one of the wonderful things about it. And talking about a minimally invasive procedure, Dr. Moore, would you say it's fairly minimally invasive?
Absolutely.
Yeah, so we're not really cutting through muscle or tendons to place these stimulators. It's a very minimally invasive procedure, just a small incision in the skin, and we place the battery under the skin, and the wires go into the epidural space. Don't have to cut through muscle or bone or tendons to do that. And we don't create chronic failed back surgery syndrome like some of the more invasive procedures can do.
So you were just talking about how the stimulator is placed under the skin. Someone wants to know, is that visible? Can we see that? Is it going to be like this unsightly bump that's an obvious thing? You know, swimsuit season. This is a concern, Dr. Malone.
Do they want to see my stimulator? Because I'm a former failed back surgeon.
All right.
And I have a stimulator right here.
Oh,
you can see I'm a fairly thin person, and you can barely kind of touch.
So just live in person, I mean, it is the tiniest of little. Protruding just a hair. I mean, you can't even see it.
And it doesn't bother me.
Just barely feel the battery under the skin. And the other thing is, it's modifiable. You have your own remote. You can control and program this your own way. And if over time your pain gets better, you can actually turn it off. You don't even necessarily have to have it removed. So it's highly modifiable and programmable. The technology of these devices today is much better than when they were originally, introduced and developed approximately 20 years ago.
Absolutely.
So for neurosurgery, Dr. Moore, could you tell us specifically if somebody just falls in love with you today on this Facebook Live, where can they go to see you? Which clinics do you work at?
That's a great question. They can just call our main number and we can ask what clinic's more convenient for them and schedule them anywhere. But we go as far south as Kyle, and we go over to Bastrop. We have offices in South Austin. We have offices in Round Rock. My partner, Dr. Harper, also goes to Georgetown and as far north as Waco. So we've pretty much got you covered anywhere in the greater Austin area and beyond, even as far as Amarillo.
Yes, we do blanket Texas. Question about lumbar fusion. If somebody has a lumbar fusion, could they still be a candidate for stimulator?
Absolutely. Sometimes those are the perfect candidates. So if a patient's had a prior lumbar fusion, there's a couple questions we ask. We ask, one, are they having residual pain since the time of the surgery, or is it recurrent new pain? We try to figure out if the patient has a condition called pseudoarthrosis, which basically means failed fusion. So lots of times the fusion doesn't fuse successfully, and you need to evaluate if the patient's unstable or if they have progressive neurologic deficits. If they don't have those conditions and they have chronic pain that persists after the fusion, we want to look and see if they have what's called adjacent segment disease. When you have a fusion, it can put a lot of tension on the other disc, so the disc above or below or both, the fusion can actually deteriorate. And then if all of those questions are answered, I think stimulation is a great option in those patients. And also it's simpler. So in a lot of patients, even if they do have adjacent segment disease, I'll tell them, we could do another fusion on you, a larger fusion, but let's try a spinal cord stimulator trial and see. It might give you a good enough quality of life, and it's a simple outpatient procedure, and then we can hold off on that fusion for a while or maybe even indefinitely. So that's a great question.
So Dr. Moore, if you have a horrible accident, say car wreck or sports injury, you have an unstable spine maybe, is that when you need a lumbar fusion?
Yeah, that's a great question.
Yeah.
So the indications for lumbar fusion, have changed over the years. I'm fairly conservative with my fusion approach. I do a lot more decompressions than fusions simply because I treat more nerve injury and nerve deficits than mechanical back pain. So in the past, patients with mechanical back pain had a lot of fusion procedures. The problem with that is back pain's multifactorial, so the fusion is going to help if you have instability or a fracture or degenerative disc disease or spondylolisthesis, which is slippage of the vertebra. But it's going to also potentially exacerbate other conditions that we spoke of previously, muscle injury, myofascial pain syndrome, facet injuries, things like that. So I traditionally use a fusion for someone with spondylolisthesis where they have slippage that's unstable with flexion extension views.
Which by this we mean the bones are actually moving when you're moving. So that's like a broken bone.
Exactly. So if they have that, or if they have fractures and the spine's unstable and you're worried about spinal cord injury, or if they have a fracture that unfortunately is bad enough that's actually resulted in a spinal cord injury to stabilize that area. So those are the primary indications for fusion.
So the red flags in that is muscle weakness.
Yes, sir.
Or severe pain going down the extremities.
Right.
Correct?
Right.
So those are the people that might need a fusion.
Possibly.
But we're the best judges of that, right? Because we do it all.
Right.
With everything from stimulation to fusions to decompressions.
Right.
And
clearly everyone with back pain does not need a fusion.
Right. Clearly. But so you do have severe back injury and you have unstable spine, you get that fusion, and a year later you still hurt like crazy.
Right.
Then what do you do?
That's a great question. So you want to follow up that patient, do another MRI, make sure that you didn't miss anything at the initial time, and then if they just kind of have chronic pain from that, they don't have the pseudoarthrosis, they don't have another disc herniation compressing a nerve that's putting their function at risk, stimulation is a great option for them.
And then stimulation, how many chronic pain, severe back injury patients are cured by stimulation at this point?
Greater than 85% have substantial improvement in their quality of life with stimulation.
So that's pretty amazing, right?
Yes, sir.
I mean, in all the years I've practiced medicine, that never used to be true.
Right.
But in the last 3 or 4 or 5 years, that is now a true thing.
Right.
You can actually cure this horrible chronic back pain, right? Which is amazing.
Absolutely.
Yeah, because there's thousands, hundreds of thousands, if not millions of Americans that suffer from this.
Yes.
Yeah, amazing.
So doctors, I'm just going to jump in here. We have one last question for you. Especially with travel opening up, CDC guidelines loosening a bit. If someone's traveling and they're going through the security checkpoints, what does that look like with TSA? Are these stimulators going to be setting off metal detectors? What is that experience like?
Well, I can address that question, Sam. Thank you. When I first got my stimulator 5 years ago, the manufacturer warned me that it might set off a metal detector, but it never has. I've been through the airport hundreds of times in the last 5 years. Never has it set off any detector. The first time I went through the airport, in fact, I tried to show the attendant my card and explain that I have an implant, and she was like, I don't know what you're talking about, just go through. and I did, and it was fine.
We're going to wrap this up, gentlemen. Is there any last things you'd like to add for the viewers out there watching today?
I just want to get the word out that there's no need to suffer with this chronic back pain medicine every 4 hours, heavy duty medicine, stuff that your doctor doesn't even want to prescribe anymore with all of the opioid issues we've been having as a nation. You don't need to suffer like that, and you don't need to keep looking for the next source of medicine. Come in, see us, we'll give you whatever medicine you need, absolutely, but we can fix this chronic pain.
Wonderful. Well, that's all the time we have for today. As always, thank you for your participation. We hope that you learned a couple things that might be able to help you or someone you know from suffering with pain. Please stay tuned for our next event, and remember, at Advanced Pain Care, the pain stops here.